Good morning, everyone. My name is Councilmember Corey Johnson. I am chair of the Council's Committee on Health. I want to thank my friend and colleague, Councilmember Elizabeth Crowley, chair of the Committee on Fire and Criminal Justice Services, for joining us today for this important oversight and legislative hearing. Councilmember Crowley has been an extraordinary leader on correctional issues. Our hearing today, entitled Healthcare Delivery in the New York City Jails, Examining Quality of Care and Access to Care, along with Introduction Number 440, a bill that I introduced, is an opportunity to examine the discrete and incredibly important issue of health services in jails. This is just one component of the complex and interlocking problem facing our city's correctional facilities. With proper examination, I think that we can better understand how the system is performing, who is accountable, and what we can do to fix it. The availability of and timely access to medical and mental health care is determinative of health outcomes. The people coming into our city's jails are overwhelmingly poor and are overwhelmingly sick and desperately in need of quality health services. Inmates enter the system with high rates of HIV, hepatitis C, asthma, hypertension, and substance abuse, all at rates significantly higher than the general population. We are concerned that the contractor providing health services in many of our city's jails, Corizon Health, Inc., formerly known as Prison Health Services, is not doing an adequate job. The allegations that have mounted over the years suggest that Corizon is failing to provide comprehensive and safe services to people under their care. These reports suggest that treatment provided to inmates may have been a factor in at least 15 deaths over the past 5 years, and that these deaths may have been preventable. In all of these cases, quality or timeliness of health care was a key issue. Furthermore, a recent report by the New York State Commission on Corrections investigating the death of Bradley Ballard, an inmate at Rikers, called the mental and medical care he received, quote, so incompetent and inadequate as to shock the conscience, unquote. The State Commission on Corrections report recommended that DOHMH consider whether Corizon is, quote, fit to continue in light of delivery of flagrantly inadequate, substandard, and dangerous medical and mental health care to Bradley Ballard, unquote. These allegations are incredibly damning, and I am eager to hear where the Department of Health and Mental Hygiene is in its comprehensive review of Corizon and the services it provides. The first step in addressing these problems is getting a better picture of the adequacy of services being provided. This hearing, in Introduction Number 440, would improve transparency by identifying the metrics by which we should evaluate this system. We need to hold the providers and agencies that oversee them responsible for performance in key areas like wait times, sick calls, access to medication, follow-up visits, and preventable hospitalizations. This reporting lays the groundwork for a broader conversation about accountability. In such a complex system, where the Department of Corrections runs the facilities, the Department of Mental Health and Hygiene oversees Corizon, and Corizon manages the affiliate companies providing care, it is difficult to know who is responsible for what. We need to peel back these layers of governance and figure out where the buck actually stops. It's easy to blame mistakes and tragedies on the other guy, but ultimately, someone has to be the adult in the room. I look forward to an honest conversation today to help get a better understanding of these roles and to hopefully lay the basis for future collaboration. It is no secret that the city's jail system is in crisis. With an investigation by the Justice Department into the treatment of juveniles, the debate roiling around the issue of punitive segregation, and the mayor's task force on behavioral health, we have a real opportunity here to look at the problem differently and do something bold for our system. We can't lose sight of the fact that many people in these facilities haven't been found guilty of anything. It mocks our justice system's principle of innocence until proven guilty. If somewhere along the way you might die because you didn't get your medication in time, a follow-up exam, or guards didn't take your pleas for help seriously. At the same time, I think it is easy to underestimate how hard it actually is to provide services at a correctional facility. Healthcare staffers are too often victims of violence, and corrections officers may not have the training or knowledge to know when an inmate needs medical attention. Between 2013 and 2014, 39 assaults on civilian staff have occurred, mostly against healthcare workers. I am grateful to the over 1,100 healthcare staff who dedicate themselves to a helping profession in one of the most challenging environments that you could imagine. So while we can and must do more to provide better care to these inmates, I believe that we can improve health care by having fewer inmates to begin with. That means keeping kids out of jail and doing more to divert people from the criminal justice system who have behavioral and mental health needs. It also means innovative measures like the Speaker's proposal to create a bail fund, so a turnstile jumper doesn't spend 2 years in Rikers because he didn't have $200 for bail. The challenges before our jail system are deep, complicated, and seemingly intractable. We indeed have a lot of work to do. Health is just one piece of a very complicated puzzle. Of course, other factors influence healthcare delivery, but that can't deter us from holding our healthcare providers and the city's oversight of those providers to the highest standard. This is one piece of the puzzle that I know that we can do something about. I want to acknowledge my colleagues on the Health Committee who have joined us today. We're joined by Councilmember Rosie Mendez, who has also been a leader on these issues. I want to thank my legislative director, Louis Cholden Brown, Health Committee Counsel Dan Hafetz, Policy Analyst for the Health Committee, Crystal Pond, Crillian Francisco, the Finance Analyst for the Health Committee, and the staff for the Committee on Fire and Criminal Justice Services for their work in preparing for today's hearing. I also want to thank Councilmember Crowley's legislative director, Jeff Mailman, who is always very helpful and important in preparing for these hearings. And before I turn it over to Councilmember Crowley, today is not about trying to make one person the enemy. Today is about, as I said, looking at a complicated puzzle before us under challenging and difficult circumstances and understanding what we can do better. And it's also about ultimately figuring out who is responsible. Where does the buck stop? I visited Rikers at the beginning of December, and the people who are there working are dedicated, compassionate people that are trying to do the best. But right now, we don't know how to judge the contracted provider, Corizon, and I want to figure that out. $400 million is a lot of money to spend in our city budget. So it's time to look and see how we create greater accountability. With that, I want to turn it over to my colleague and friend who's going to co-chair this hearing with me, Councilmember and Chair Elizabeth Crowley.
Good morning. Thank you, Chair Johnson. My name is Elizabeth Crowley. I am the chair of the Fire and Criminal Justice Services Committee. I want to thank Chair Corey Johnson for his leadership on this issue and the staff for helping to prepare the committee for this oversight hearing. Today we will also hear Councilmember Johnson's bill, Intro 440, which will bring much needed transparency into the medical care that is administered on Rikers Island. As the chair of this committee, I have serious concerns about the quality of health care administered to inmates and the safety of health care providers in clinics on Rikers Island, especially when they are seeing violent inmates. My concerns are only heightened by the hundreds of lawsuits against Corizon that have been brought up by inmates, not only here in New York City, but across the country. The medical mistakes that have brought about lawsuits seem to be the result of medical staff that is being spread too thin. Providing medical services to those detained is a basic right. Inmates in need of medical attention must have timely access to such care. When someone is denied such care, the consequences are often tragic. Even worse, when inmates are seen by the medical staff and sent back to their cells with the wrong diagnosis, this not only wastes time, but can lead to avoidable deaths. An example reported in the Associated Press about a 19-year-old who complained about chest pain for 7 months was seen 8 different times and never given a chest x-ray. He died, a 19-year-old, in 2013 from a tear in the aorta. I am concerned that Corizon, a for-profit company, has indemnification and is not responsible for malpractice, as this city covers the costs of its lawsuits. I am also concerned about the costs of the contracts and why our city does not incorporate these health services into our HHC system. Over the past several years, the number of inmates diagnosed with mental health illness has grown substantially, accounting for approximately 40% of the population. I am concerned that there is inadequate staffing for mental health professionals for this mental health needs on Rikers Island. I'm interested in learning about how Corizon assesses and treats the growing population with mental illness, especially those who are under 21. Equally troubling are the reports about healthcare workers being beaten and physically abused by inmates. Inmate assaults on healthcare staff has rose 144% from 2013 to 2014. This committee is concerned that DOC is not doing enough to protect the staff from dangerous inmates and not providing enough staff to ensure their safety. The physical layouts of some of these clinics create safety risks that place an undue burden on doctors and medical staff. I am interested to learn about what plans are in place to address these physical structural issues. The mayor's management report provides insufficient performance indicators to determine whether or not inmates are receiving timely access to health services. Chair Johnson's bill addresses this deficiency, and I have signed on as a co-sponsor. Separate from these fundamentally important safety issues are funding issues with correctional health care. This committee is interested in learning more about to what extent the state and federal governments fund our healthcare correctional facilities, and what DOC has made to obtain what efforts DOC has made to obtain such funding from outside sources. Ultimately, we would all like an efficient and effective correctional healthcare system. This committee is interested in discussing what steps the DOC is taking to address the systematic problems that have continued to pervade our system. The committee is also interested in discussing what steps the council can take to address these important issues. I look forward to hearing from Corizon, DOC, and DOH-MH, and from all of the interested parties. I will now turn it back to Chair Johnson. Thank you.
Thank you, Chair Crowley. We have been joined by Councilmember Andrew Cohen, who is chair of the Council's Committee on Mental Health. With that, I want to, and we've also been joined by a member of the Health Committee, Councilmember Peter Koo from Queens, and Councilmember Peter Vallone from Queens, Paul Vallone from Queens. I've never done that before. Sorry, Paul. So with that, we're going to start with our first panel. It is the Administration, the Department of Health and Mental Hygiene, and the Department of Corrections. We're joined by Dr. Sonia Angel, the Deputy Commissioner at DOH-MH, Homer Venters, also from the Department of Health and Mental Hygiene, and Eric Berliner, a Deputy Commissioner at the Department of Corrections. Before you start with your testimony, I have to swear you in. If you could please raise your right hand. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee, and to respond honestly to all councilmember questions? Thank you very much. You may begin in whatever order you'd like.
Thank you. Good morning, Chairs Johnson and Crowley, and members of the committee. I'm Dr. Sonia Angel, Deputy Commissioner of the Division of Prevention and Primary Care at the New York City Department of Health and Mental Hygiene. I'm joined here today to my right by Dr. Homer Venters, the Department's Assistant Commissioner for Correctional Health Services, and to my left, Eric Berliner, the Deputy Commissioner for Strategic Planning and Programs at the Department of Correction. On behalf of Commissioner Bassett and Commissioner Pont, thank you for the opportunity to testify today on the topic of health care delivery in New York City jails and Intro 440. Ensuring the delivery of quality health and mental health services in our jails is a critically important and very complicated issue, and I thank the Council today for your continued interest in it. As you know, Commissioner Bassett testified before this committee in June 2014 about the provision of correctional health and mental health services in the city's jails and on the issue of violence against healthcare workers. In the interest of time, I'll refrain from going into detail on the topics we discussed then, although I do think it's worth mentioning some of the basic facts and figures related. The Health Department is responsible for the city, under the city charter, with providing health and mental health services in the city's correctional facilities. Our mission is to provide the best possible medical assessment and treatment during an inmate's detention, as well as appropriate health and mental health discharge planning services. Our health system is a national leader in providing health care that not only addresses urgent needs for patients while in jail, but also provides preventive and chronic care interventions like testing for HIV, hepatitis, and sexually transmitted infections, as well as vaccines that can prevent illness later in life. We pursue these goals by focusing on patient safety, population health, and human rights as an essential element of our health system. High-quality correctional health services are critical for patient safety and health while they're in jail, but they're also important in safeguarding the health of our communities, those communities to which individuals discharged from jail return. All inmates receive a full medical intake examination within their first 24 hours of entering custody. New York City is a national leader in this regard, as it takes most jurisdictions 1 and 2 weeks to complete such exams. This intake exam allows us to screen patients and guides referral to a range of services they may need, and includes a comprehensive health assessment, sexually transmitted disease screening, and initial mental health assessment. These inmates enter the jail system with a high burden of disease. Rates of HIV, hepatitis C, asthma, hypertension, and substance use are all significantly higher than they are among the general population, as noted earlier by Chair Johnson. The intake screenings really help us to guide further treatment, discharge planning, and entitlement applications. Approximately 11,000 inmates are housed within the jail's 12 facilities, and approximately 70,000 admissions occur annually in the jail system. Each month, the department provides over 65,000 healthcare visits in jail facilities, most of which occur at Rikers Island. We also provide discharge planning to eligible inmates with mental illness. These discharge services are provided to approximately 20,000 individuals annually. They include arranging for post-release medical and mental health care, applying for or reactivating Medicaid, applying for public assistance, providing a supply of and prescription for medications, arranging for transportation, and organizing post-release follow-up. The department is also a national leader in the adoption and use of prevention-oriented health care records in our jail facilities, allowing our health care workers to better coordinate and provide care for our patients. Although the oversight of health services and discharge planning in the city jails is the department's responsibility, direct medical, mental health, and dental care services are performed by contracted personnel from the health services provider, Corizon, and Damien Family Care Centers. Hospital inpatient services are provided by the New York City Health and Hospitals Corporation. Corizon, the largest private for-profit correctional health services provider in the United States, manages the day-to-day medical and mental health operations at Rikers and 2 other jail facilities, employing approximately 1,100 staff to deliver this care. Damien, which employs approximately 90 staff, provides services at the Vernon C. Baines Correctional Center, a jail facility in the Bronx, which houses approximately 600 inmates. Damien is a New York state-licensed Article 28 diagnostic and treatment center and a nonprofit, federally qualified health center with a long history of providing high-quality health care to the city's underserved. Both Corizon and Damien were selected as vendors via a competitive proposal process. Solicitation for correctional health services were issued by the city in 2000, 2004, 2007, 2010, and 2012. During these solicitations, hospitals, federally qualified health centers, and healthcare networks in the city were contacted, along with national correctional health providers. Since January 2001, Corizon has received the contract to provide correctional health services for all of the city's jail facilities, with the exception of Vernon C. Baines Correctional Center. The Corizon contract is approximately $140 million per year, and it expires on December 31st, 2015. The contract with Damien is approximately $7.4 million per year and expires November 2016. Now, prior to 2007, solicitations were offered for the entire jail system. Beginning in 2007, however, solicitations were offered for individuals or groups of jails rather than a single contract for all jail facilities, with the goal of increasing the pool of potential vendor applicants, particularly community-based providers. Given that most of the patients within city jails return to their community within days or weeks of arrest, community-based providers may be able to offer greater continuity of care. Since 2007, Damien has been the only nonprofit vendor to submit a viable, comprehensive proposal. In 2013, Damien won the bid to provide care at the Vernon C. Baines Correctional Center, and the contract began in November 2013. In addition to oversight of clinical operations, discharge planning, and all other aspects of health services, the department is responsible for establishing and determining the medical and mental health policies that vendors are required to adhere to. We base all of our nursing, medical, and mental health and substance use policies and procedures on evidence-based best practices. Although Corizon and Damien are included in policy-making discussions, ultimately health and mental health care policies are designed, implemented, and measured wholly by the department. The department closely monitors our vendors through multiple lines of supervision. From a financial standpoint, our contracts are structured so that there is no incentive to limit care, medication, or treatment. From a clinical perspective, we oversee the credentialing of physicians and physician assistants and monitor compliance with all policies through a rigorous quality assurance process. Corizon and Damien undergo routine, quality, comprehensive evaluations and are responsible for meeting 40 performance measures in areas including mental care, dental care, mental health care, women's health, chronic disease, infectious disease, substance use, medical records, management, and preventable hospitalizations. The department meets weekly with our vendors to proactively identify issues and address them immediately. We also utilize rigorous morbidity and mortality reviews to assess potential errors in healthcare activities. If our vendors fail to meet the established standards, or if morbidity and mortality reviews reveal shortcomings in service, the department employs a structured process to swiftly remediate issues. This process includes the development of corrective action plans to ensure problems are addressed. In addition to measuring compliance with existing standards, the department is committed to improving the quality of care. To that end, we created a Quality Improvement Executive Committee, which is chaired by Commissioner Bassett and includes senior health department leadership. This committee is based on the approach to quality that is found in hospitals and other community health systems, and meets on a quarterly basis to review data, including quality assurance efforts, quality improvement projects, and performance indicators. As part of this effort, we are focused on empowering health staff to deliver patient-centered, high-quality care and fostering a sense of teamwork in each facility, especially among health and DOC staff in important processes such as interfacility patient transfers. Finally, we must keep our healthcare workers safe. Staff cannot be expected to meaningfully engage with patients when they are worried about their safety, and jail violence impacts workers as much as it does patients. Many assaults against staff occur in high-security housing areas where health staff must provide care because of limitations on patient movement. The administration is committed to protecting the health and safety of our healthcare workers, and the health department has been working closely with the unions, Corizon Management, and DOC to improve training and increase the availability of safety equipment, such as cameras and alarms. These are difficult issues to address, but we are making progress. Instituting routine safety communication between security and health staff, retrofitting clinics and other settings to improve staff safety, and closing units that are unsafe for staff and for patients. With respect to Intro 44, the administration supports improving transparency throughout the jail system, including in the provision of healthcare services. We share a commitment to this approach, but as the providers of healthcare, we also have a legal and ethical responsibility to protect confidentiality of our patients' health information. Although the legislation as currently written would not require the reporting of patient identifying information, the information required by this law, combined with other publicly available data, may cause the patient to become identified. In some instances, this unintended effect could violate our legal responsibility to protect the confidentiality of our medical records. This is of particular concern in the jail setting because inmates are identified by the DOC website, on the DOC website. In certain circumstances, it is statistically possible to re-identify individuals using separate data sources of demographic information. The department does believe, however, that we can meet the goals of the legislation and still protect patient confidentiality, and we would be glad to discuss this feedback in detail after the hearing. Lastly, I would like to reiterate the quality of healthcare in the city's jails requires collaboration between the Health Department, the Department of Corrections, and the vendors with whom we work. We are proud of the progress we've made to date. Our Clinical Alternatives to Punitive Segregation, so-called CAPS program, is one example how working together we can improve health outcomes for individuals at Rikers. Furthermore, the Program for Accelerating Clinical Effectiveness, the so-called PACE unit, functions well because the health and security staff train and work on the units together as a team. Likewise, the improvements that we have made in staff safety reflect routine joint meetings that occur in every jail. Likewise, the improvements that we have made in staff safety reflect routine joint meetings that occur in every jail, include line staff and managers from both health and safety and security teams. In addition, our two agencies are working closely to successfully implement initiatives developed through the Mayor's Task Force on Criminal Justice and Behavioral Health, which aim to enhance the jail system's capacity to provide therapeutic responses to inmates with acute mental health crises and individuals to care and services in the community at discharge. However, despite the success of these new programs and innovations, we recognize our work is far from done. The administration is committed to improving the services available to patients and is evaluating the best approach and model for medical and mental health care delivery in the jails beyond 2015. An interagency team, including members from the Health Department, Department of Correction, Health and Hospitals Corporation, the Law Department, and OMB, is examining potential new strategies for healthcare delivery in our jails. We are using 4 guiding principles as we consider future directions. First, maximizing existing links to the extraordinary healthcare resources of the city, such as our local hospitals and our medical schools. Second, ensuring the continuity of care between the jail and the community. Third, continuing to improve cohesion and partnership between the Department of Correction, Department of Mental Health and Mental Hygiene, and Health and Hospital Corporation. And fourth, applying national best practices for innovative quality care. Our review will be complete this summer, and we look forward to sharing the results of the analysis with the council then. Thank you again for this opportunity to testify. My colleagues and I are happy to answer any questions.
Thank you, Dr. Angel, for your testimony. When I visited Rikers Island, I was with Dr. Bassett and with Dr. Venters, and I know, again, how difficult it is. And also being there with Dr. Bassett, I know how committed, just in her bones, how committed she is to really try to turn things around and make things better on the island. So I'm not questioning the department's commitment because I know that Dr. Bassett really truly cares about trying to figure out how to improve things on the island. I do have some questions for you, and then I want to turn it over to my colleagues. Before I get into those questions, I want to recognize some of my colleagues that have now joined us. We're joined by Councilmember Danny Drum from Queens and Councilmember Fernando Cabrera from the Bronx. So I understand that last year the Department of Health and Mental Hygiene downgraded Corizon's performance from good to fair. What was the reason for this downgrade? On what basis was it made? What changed in Corizon's performance? How and to what extent does the department communicate this downgrade to Corizon? And was it accompanied with the corrective action planning that Dr. Angel talked about?
Certainly. So I will address those in order. But
you could just identify yourself.
Yeah, sorry. Dr. Homer Venters. I'm the Assistant Commissioner for the Bureau of Correctional Health Services. So I oversee healthcare in the jail system. And I report to Dr. Angel and ultimately to Dr. Bassett. So The downgrading of that evaluation, which was done by me with support by my staff, and the data from quality assurance, quality improvement, and morbidity and mortality reviews, those are three big areas of data. That downgrade really referenced two areas of concern that we had with Corizon's performance in that year, which is 2013. One was performance on mental health units, so the provision of care to the most seriously mentally ill, those who are sick enough to be in a mental observation unit. And the other was an inconsistency in the senior leadership at Corizon. Corizon had some turnover and some open, very important open lines in their senior leadership. So the way that we came to that assessment was both through looking at the performance on the units, looking at several bad patient outcomes that occurred on some of these units, one of which you've referenced, that revealed to us that some of the policies that we as a department had promulgated weren't being followed. We also looked at reports from the quality improvement efforts and also quality assurance, which is the performance indicators data that we look at. And so all of that taken together really left me with concerns about these two areas that I referenced, the performance on the mental observation units and also the consistency of the senior leadership. So in 2014, both of those areas have improved dramatically. If I look at the mental observation areas, you visited the CAPS unit. So one of the things we realized after the really horrible, tragic case you referenced earlier was that in the mental observation areas where we have our more seriously mentally ill, we did not have enough staff. And so the mental health staff that were tasked with caring for the sickest patients in the whole jail system were running from unit to unit to unit, trying to find the sickest people or the people that were most obviously in need of their care.
When you say we, are you referencing the department or Corizon?
Yeah, the department. So Corizon follows the policies that we set forth, and they staff based on the amount of money that comes through the city and comes through the design matrix that we have. And so I think that the CAPS unit you were on and the PACE units, which have just recently opened, really are the most important systems response to some of these horrible cases. When we find bad outcomes in the jails, they're generally the result of systems failures, not of individual failures. That's a tenet of improving healthcare. It's a tenet of improving large, complex systems. And so while we did find that Corizon had failings that led to the downgrade of their overall rating, they went from good to fair, and in that fair, as I mentioned, there were two subpar areas. We had very specific corrective action plans for them. So on one of the mental health units where we had a bad outcome, the rounding that was supposed to happen every day wasn't happening. So within 24 hours, we had developed a system to ensure that not only does the mental health leader of the building know that rounding has been done, but all the senior leadership all the way up to myself can attest to that. And so that's the kind of systems response that comes out of a corrective action plan that results from a bad outcome.
So, but that seems like a pretty big deal to me. A downgrade from good to fair seems like it's something, as you said, there are clear failings. Something's not working properly. And my question is that the department's fault because you were not providing the proper instruction and supervision in staffing, in overseeing Corizon and their employees in the proper way? Or is that Corizon's inability to actually deliver these things in the most appropriate and adequate way? Who ultimately is responsible?
Well, I'll reference something that you mentioned earlier, which is there's no single person that's responsible for this. I'm responsible for healthcare in the jails, so I'm responsible for the failings of policy and procedure. I think, however, that we had experienced in a very short order about a 40% expansion in the number of seriously mentally ill people in that jail. And so in a very short period of time, we had a rapid expansion of the number of people that needed high-level housing. And so the Corizon staff, along with the Correctional Health Services staff, our mental health leadership, really were working to find the sickest people. But what we didn't have in place was adequate systems to ensure not just that care was delivered, but that when there was a lapse, if we couldn't find a patient, for instance, if a patient had been transferred multiple times, that we knew how to find that patient in an expeditious manner. We have that now. Right now, people who come back from the hospital, our sickest patients, they go into a PACE unit. It was the first PACE unit we opened with support from the city. And that PACE unit has staff all throughout the day. They have multiple levels of staff that we didn't have before, like the treatment aides you saw, talking to the patients, finding out who's not doing well, who is doing well.
How new is all of that?
This is all the CAPS unit, which you visited, is about 1.5 years old. The 2 PACE units have just opened in the last 3 months, and we have 2 more that we've received funding more, so we'll have a total of 4 of these PACE units open.
How many inmates does that cover out of the entire population? How many people are we talking about that are housed in these units?
Right now, when we get the 4th PACE unit open, we'll have between 100 and 200. And so we have a footprint. The people who are seriously mentally ill who need high-level care like this is probably 600 or 800. And so that's an ongoing challenge that we're really working with, is how can we put together data from these units. We have preliminary data to show that people fare much better in these units than the traditional units. That's clear. But we need to assemble that data, report all of this to oversight and stakeholders around us, to gather support for the next steps.
So it sounds like that it's your belief, Dr. Venters, that we're moving in the right direction and that there have been some key improvements with the CAPS unit and with the PACE unit coming online, but still we don't have the bandwidth or space available to treat all of the seriously mentally ill people that would need these specialty units. Is that right?
I think that's a fair characterization.
And part of the money that was put in the November plan and in last year's budget, the tens of millions of dollars, was to set up these units to start to take care of the seriously mentally ill population at Rikers.
Absolutely.
So in what areas do you still currently see Corizon performing poorly, and where do they need improvement?
I don't currently see poor performance in any of the areas that we oversee. I think there are several areas for improvement that we think are really critical. One that we've also received support for is development of treatment for people with substance abuse disorders. So the 2 most common sets of diagnoses for people that come to jail are mental health and substance use disorders. Those far outpace any other medical diagnosis. And we have spoken at length about treatment of mental health disorders, seriously mentally ill people. We really pay scant attention to people who come into jail with profound substance abuse concerns. Those often are the reason people come to jail. They certainly are much more determinative in post-jail mortality. So the big bump that we see in the rate of death of people who leave jail and prison, including in New York City, is often linked to substance abuse. And so we really need to push ourselves, and we're doing this right now, to develop a more comprehensive approach, not just for a small number of people who might go through what we would think of as a day treatment center, which we have in Rikers, but actually a much more broad-based approach. And so we're working with Corizon to develop, with the funding we received through the task force, an approach that will allow us to not just identify people who come into the jail with substance abuse disorders, but also do discharge planning for them so that we connect them to some resource after jail that could potentially be life-saving.
Do the Department of Corrections staff and the health staff on the island have the opportunity to train together?
Absolutely. So that's another example of what we've started to do very well, but we need to do much, much more of. The unit that you were on, and for everybody here who's been on the CAPS unit or the PACE unit, those units don't open until we've identified the staff that are going to work there every day and that they train together as a team. They're invested in finding problems. They're invested in fixing them before they become, could lead to a bad outcome. So that kind of training we need much more of. So we've been working, again, with task force support to develop crisis intervention teams where, it's a horrible circumstance when you have a seriously mentally ill person somewhere in the jail and the only possible response is a probe team. I mean, it almost predicts a horrible outcome. So the crisis intervention model, which is used by police departments all over the country and some state prisons, is something that we're developing so that we can train together a team that can respond to, patients that are having problems in the jail.
So the contract with Corizon and its affiliates, as Chair Crowley mentioned in her opening, and I'm going to go to her in a moment, I know a lot of my colleagues have questions, it has an indemnification clause by which the city will pay for Corizon's legal expenses in litigation and malpractice suits. I want to understand if this is typical for city contractors. Is this included in Damien's contract for the barge? And is this typical for contractors providing health services for jails across the country?
So I'll have to refer some of the legal fine points to the corporate counsel and our counsel. I will say, however,
Are they here?
Corp counsel, I don't believe is. So the legal points, I'm not
Okay.
expert in. I will say, however, that Damien has the same type of contract with the city that involves indemnification. However, I will say that very few jails around this country have any of the oversight that we have here. If you go to most big jails around the country, you have a handful of people involved in overseeing a contract. None of them are doctors. None of them see patients in the jails. And you'll rarely have performance indicators or liquidated damages or the whole raft of oversight that we have here. And so much of this is unique to our setting. But the actual legal question about the indemnification, maybe we can follow up with you on.
Yeah, I mean, you didn't answer the question, which it's fine because you're not with the law department, but I take real issue with the fact that if we have a contracted out provider that is having serious problems where there are preventable deaths, and then the city faces malpractice suits or negligence suits over that we are in fact paying those expenses when an outside for-profit contractor has made serious mistakes that have resulted in death. I take issue with that, and I think that the city should really look on whether or not that indemnification clause should be included if this contract does in fact get renewed at the end of this year. So I have a lot more questions, but I want to turn it over to my chair, Chair Crowley, and then I also want to then go to Councilmember Cohen, who chairs the Committee on Mental Health, and then we have a bunch of other questions as well from council members, and then I'll come back for a second round. Chair Crowley.
Thank you, Chair Johnson. To follow up Chair Johnson's line of questions about indemnification and the Corizon contract, why don't we use HHC as a system? I know years ago, before we contracted with Corizon, we did. And we have some of the best public hospitals in the world. And we have them, in comparison to private hospitals in the city, we have some of the best hospitals that are public. Why can't we have that care for our inmates? Why are we contracting out to a profit company and then covering the cost of their lawsuits?
I think your point is an excellent point. We have some of the most amazing medical healthcare systems in the country here, and really an extraordinary bounty of resources within the City of New York through Health and Hospitals Corporation and through our medical schools. And that's absolutely one of the areas that we are exploring. We fully recognize that the model of care delivery that we currently have isn't meeting the goals of this administration and our community at large. So that's one of the areas that we're looking very closely at.
Sorry, if the model is not meeting the goals, then how did it receive a fair rating? I would think that when you're saying fair, it's okay, it's good.
So I appreciate what you're saying. The rating that they receive is based upon the requirements of the contract. That's a reflection in how they're being evaluated by the contract. The model of care that I'm referring to is really thinking about the environment and the way in which we're serving our inmates' healthcare needs within the jails at large, which includes the Corizon contract, but also includes the whole sort of complex environment within which we provide care, how we work closely with Department of Corrections, and how, as you mentioned, we think about pulling in these resources that we have through health and hospital corporations,
Sure.
et cetera.
No,
So
we're only a few months away from the contract ending.
Yes.
And we have an opportunity here to improve healthcare delivery in our jails.
yes.
And I firmly believe that if we incorporate the HHC system more, or have the system run the jails, that our inmates will have better health care, and we'll see fewer deaths and probably save a significant amount of money in lawsuits. Now, what is the health department doing in preparation to see if we can put this together in a short amount of time?
Yeah, so I absolutely reassure you that we're aware of the contract requirements in terms of when the contract will expire. And we're working very closely with City Hall, with Health and Hospital Corporation, with Department of Corrections, with OMB, and with the legal department to address this. So this is absolutely a priority as we think about how to structure the best care delivery. It includes your observation that Health and Hospitals Corporation is an incredible resource. That is fully incorporated, and they're at the table in these discussions. So I'm sorry that we don't come today with the model to present to you in its entirety. It's a complicated issue, and that's not an excuse. It's just a comment about how carefully all of the different areas need to be addressed. It's not as simple as simply turning over care to Health and Hospitals Corporation.
That.
Yeah.
When our inmates leave the jail, when they're diagnosed or when they need serious care, they go to one of our hospitals. They'll either go to Bellevue or they'll go to Elmhurst Hospital, where they will receive better care, not only because they're in the hospital, but because there's more staff there to meet their needs. But what many of my colleagues may not realize is that when they leave the island, then their Medicaid kicks in again. When they go to one of these hospitals, the federal government and the state starts providing some of that cost. What goes into this? Who's funding this Corizon contract? I know it comes from the DOH, but how much of federal or state resources are covering the cost of this contract?
Yeah. We have a very small grant from the federal government to support a substance abuse house that has for co-occurring disorders, but aside from that, none of it, because there's a federal prohibition on this. The Social Security Act prohibits billing of Medicaid for care of people who are
I
in
figured
jail.
that much. It's unfortunate because, as you mentioned, 40% of the inmate population has a mental health diagnosis. Of that, anywhere from 600 to 800 in any given day has a serious mental health diagnosis. A recent report that this administration put out a few months ago documented that there are approximately 300 people who circle in and out of our jail system a number of times each year that have been diagnosed with a significant mental health diagnosis. Those people, if they were put in a different facility that wasn't a jail, we may be able to access federal dollars and therefore reduce the number of people who were in the jail with care. So what is the plan to divert those inmates from revisiting? I know in the budget that we okayed in November, we gave you more money for discharge planning and monitoring inmates after they leave so that they don't end up back in. And, for the purpose of the committee, some people end up back in jail who fall within this category for sleeping in a stairwell. And so often, not only do they have significant diagnoses, they also have substance abuse problems. So what are we doing as a city to prevent that population from circling in and out of the system and to make sure that they're getting the health care that they deserve and that we're making sure the federal government is helping towards paying for that?
That's a great point.
So those are important points because the fact is there are very few problems that get better in jail. So discharge planning, you mentioned, is our obligation, and we want to do more of it with the support I mentioned earlier on the substance abuse treatment and discharge planning. However, our agency and the police department have received money through the task force, and that's not our area of expertise, but in support of diversion centers, which will allow people who heretofore would have gone through the criminal justice pipeline to go into treatment out on the street level when the police department has an initial contact with them. So another part of our agency
Has that started yet or still in planning stages?
They're in the planning stages, but I have to admit we would have to consult with the other part of our agency and the police department because they're the ones that are rolling out this initiative. But it goes exactly to the point you raised.
It says that we're spending $1.175 million and that we've hired in your division or in healthcare delivery, there's going to be 28 people hired in this fiscal year. Have you hired those people?
Some of those have been hired. One of the things so there's several new things that aren't the diversion centers I mentioned, but we, for instance, the substance abuse planning and treatment, that program we're just now designing and we'll start hiring people for that fairly soon. I think that we also have another initiative, the crisis intervention teams I mentioned. We plan to have those rolled out by the summer. And then we have a third.
Where do your crisis intervention teams work? Where are they meant to work? In DOC facilities?
Yes. So in jails that have a mental observation unit in them.
What type of crisis are they looking to prevent or intervene upon?
The simplest way to describe them is something that would elicit a probe team today. That is a response of DOC officers with riot gear and batons and shields when something that elicits that response happens in a mental observation unit, instead, we're going to have a crisis intervention team that responds. That's a team of both mental health and specially trained DOC officers to de-escalate.
Are those officers being trained right now?
No, we're finalizing the training model. We actually have to, because this is new for jails, there are some prisons that do this, and there are some police departments that do this. We actually, right now, are working very hard to find people that can adequately train the health staff and the correctional staff in the jail setting, because jails are very chaotic. It's different than training police officers. It's different than training people in a state prison. But we plan to have that rolled out by this summer.
Okay. So earlier you mentioned because you downgraded Corizon's rating, it had to do a lot with how they were working with the mental health population. And you've mentioned that you're expanding the CAPS unit and creating a PACE unit. How is a PACE unit different than a CAPS unit? You also mentioned that it's only still serving 100 to 200 people, yet the population in need is 600 to 800. How did you increase? Is it just by opening the new units, or was there a significant number of mental health staff put on to the Corizon contract? Did you require them to hire more people?
Absolutely, and so that's actually the expansion of the mental health staffing is the primary reason for the expansion. You've seen the amount of the Corizon contract go from about $125 million to about $140 million, and that's primarily expansion of hiring more mental health staff. So the CAPS unit was the first of these new units open about a year and a half ago, and that was because in the jail system, we had a very problematic practice of taking seriously mentally ill people and putting them in solitary confinement. It was called the Maui. Many people in this room are familiar with, and we documented through quite a bit of data analysis, the bad outcomes associated with that. So our first, most pressing job was to get seriously mentally ill people out of solitary confinement. And so that was the creation of the CAPS unit a year and a half ago. So that was to take people who had some problem with the jail rule, find a purely clinical setting for them.
And just to examine that population a little bit further, are these people who are in Rikers Island because they've been arrested for violent crime, or are they somebody who might have been sleeping in the stairwell, where you could possibly go to a judge and work out a situation where you could take them off the island and put them in a real hospital facility, and whereby charge the government, the federal government, rather than using your limited resources?
So it's a mixture of both, but I would say overall, most of the people in jail in Rikers and across the country are there for nonviolent reasons.
Nonviolent.
That's right.
So is there a plan in place other than diverting them within the police department, or to try to take because you're backlogged, you're super backlogged, and you don't have a plan that's going to meet the 600 to 800 people anytime soon, it appears. Because a year or two ago, you were serving about 90 people in the CAPS unit. It started under the previous administration. And now you've expanded to somewhere between 100 and 200. You're not clear about the number of beds, which is still somewhere serving less than 25% of the population that needs it.
I apologize. So I was referencing the PACE units, which are new. So you referenced the footprint of the CAPS units. Those were the first to open about a year and a half ago. Once we opened the CAPS unit, we had such dramatic improvements in the clinical outcomes of patients, reductions in self-harm, improvements in medication management. People take their medicines. People don't lash out. We decided that what we needed to do is not simply have that for people who had a problem with the jail rule, but have it for the people who are in mental observation units. And so the PACE units are simply that commitment of high level, lots of staff and lots of programming to the MO.
I'm going to let my colleagues ask a few more questions, but I just want to clarify the answers to those questions. Now, CAPS is often a diversion to punitive segregated housing. So they've done something or been accused of and found to have infractions. PACE as well? Is that somebody?
No, PACE is for just taking regular mental health units, high-level mental health units, but giving them really the staff they need.
And just if you could clarify the number of beds in each of those units.
Sure. So I think the confusion is we've opened up 2 of the PACE units, so that's about 60 beds. Okay. We have 2 more to go, which we're going to open up in the coming months. And so, that will get us to well over 100, maybe 150 for the PACE footprint. But as I said, we have many more mental observations.
And then just how many beds are in CAPS?
I would say probably about 60.
Okay, that's it. I'll come back around for questions. Thank you, Chair Johnson.
Thank you, Chair Crowley. I want to go to Chair Cohen, followed by Councilmember Vallone.
Good morning. Thank you for your testimony. Someone has tried to explain this to me before, and I didn't understand it, so I'm going to try again. In terms of the budget for the contract, the $140 million, you said there's no disincentives to provide service. Could you explain to me how that works maybe one more time so that I'll try my best?
No, so absolutely, I'm happy to do so. So the way it's structured with the Corizon contract is it's something called a cost plus contract, in that Corizon directly bills us for all allowable items within the contract. So these are largely personnel services. The Department of Health and Mental Hygiene pays directly for all medications, for all off-island services, so sending somebody to a specialty service off-island, or for hospitalizations as mentioned earlier. So there is no incentive for Corizon not to provide those medications, services, because it wouldn't lead to any increase in profits. The one thing that this Corizon contract does have is a fixed overhead of $5.5 million, which equals about a 4% profit rate. The one variable item within the Corizon contract covers those facilities which are off-island, and for those they get a 4.25 overhead. Those can vary. So if we open a new facility, then they would get additional funds for that. So there, in that sense, there is no incentive for Corizon to decide that they don't want to provide a specific medication, that they don't want to send them to the hospital if they need to be seen otherwise, et cetera.
So there's no actual cap, in other words, on the healthcare costs in the city prison system. It's just consistently running a certain number.
Yeah, so the contract is designed, it's about $140 million to cover, as mentioned, the Corizon largely covers the personnel services. So it's based upon a projected understanding of what the personnel services are for all of the healthcare delivery.
I do understand. Thank you.
Yeah, good.
The mental observation units are different than the CAPS and the PACE unit. That's a third category.
So I apologize. This is our unfortunate nomenclature overload. So the PACE units are actually just regular mental observation units that we've converted to this higher level of staffing. The CAPS unit is different because, as I mentioned, the CAPS unit is for people who have serious mental illness who had some problem with jail rules, and instead of having them go into solitary confinement, we think they should go into treatment unit, and so that's what the CAPS unit is. The PACE units, however, represent, we have about 20 mental observation units around the jail system. So these are places where people with mental health problems go because they need a higher level of staffing, they need to be seen much more frequently, they need help with medicines. So in that around 20 or so mental observation units, depending on which time of the year you would have checked, we've secured funding to convert 4 of those to a much higher level of staffing, and those are the PACE units. And so what we've done is with Dr. Elizabeth Ford, who's here with us today, who just actually came over from Bellevue. She set up and ran the forensic ward at Bellevue, which has taken such great care of our patients for years. So she has come over to lead our mental health service in the jail system, and so what we're doing under her guidance is taking the funding that we've secured from the city and coming up with special high-intensity units, the PACE units, for people with the most serious mental health concerns. So the first one we opened was for people returning from the hospital. The second one is for people who are subacute, who might be on the way up, might be getting worse and needing to go to the hospital. And so as we roll out these PACE units, as we secure funding for them and really cement the data behind them to support what we see every day, which is the much better outcomes for our patients, we'll probably end up with a network of units that are somewhat specialized, like you would see in a hospital setting. If you go to an inpatient psychiatric facility, you don't have a bunch of units that are all the same. You have different stripes for different needs for the patients.
Commissioner, you made reference in your testimony to a rapid expansion of the mentally ill population. I wonder if that's really a rapid expansion or a rapid recognition.
I'll ask Dr. Venters to respond to the specific data related to that element, because the recognition relates to diagnoses as well. So,
So we have seen over the years an increase in the share of the population that comes into the mental health service. I think also we've seen from year to year changes by facility in the number of seriously mentally ill people there. The thing I referenced was specific to AMKC, this building. And so we've had a pretty consistent percentage of the population that's seriously mentally ill over the years. But what happens is as we build new units, as we move new units around, we may have many more seriously mentally ill people in a building from one year to the next. And so that's important for the staff because that means a lot more work for them. And what is important to remember is seriously mentally ill patients, and this is true in the community, in the United States, persons who are seriously mentally ill live about 20 years less than everybody else. That's not from suicide. That's from chronic medical problems that are unattended. So when we see an increase in the share of seriously mentally ill patients in a jail like we did in AMKC, what that means is a lot more mental health work and a lot more medical work, and that can overwhelm a facility very quickly. And so the extent to which a jail is either about something like that or a jail becomes something about like focused on punishment, what you see is it has unintended consequences on the medical service, the nursing service, the discharge planning service. And so that's what happened in AMKC. And I think that with the PACE units opening up in AMKC, we're meeting our commitment to those patients.
It seems, though, by your own testimony, that at any given time, 2/3 of the seriously mentally ill inmates are not in a CAPS or PACE unit. That's obvious. I think that's a serious concern of everybody here on in the council.
It's a concern of ours. I mean, we asked for this money. We asked for this because we saw bad outcomes among our patients. Dr. Ford, myself, we see patients in the jails, the Corizon providers, the Damien providers. They're on the front lines caring for these patients. The DOC officers who are there when a patient doesn't get their medication or doesn't get access to the care they need, they really pay the price, as does the patient. So we are committed to bringing all the services and care we need to these patients. I will say that having opened the first few of these PACE units, we're getting the sickest patients and the whole mental health footprint into those units. That is going to take stress off of the rest of the footprint of the mental observation areas. But we don't by any circumstance think that we're done improving this mental health system.
I mean, though, I wonder if you don't think that CAPS and PACE is sort of a floor, a minimum standard that seriously mentally ill inmates need to be, that we're not meeting that challenge. We're not meeting, again, to treat inmates humanely who have serious mental health issues, that they're not being provided in an appropriate facility. I think we need a rapid response to trying to get at least, again, a floor that there's standardized inmate care for people with serious mental health problems.
I agree.
I have a couple more. You testified that obviously that Social Security prevents Medicaid from reimbursement. What about, but HIPAA you think is applicable in the correction system?
Yeah, absolutely. I mean, I'll let Dr. Angel.
Yeah,
so we're in a unique setting because we care for our patients. Our primary obligation is to the health and human rights of our patients in the jails. That's number one. We, however, need to partner with the Department of Corrections and other city agencies in order to provide that care. And so what that means is there are some types of information that we do want to share, but in general, HIPAA, and we have our own internal policies that are actually not just from HIPAA, but there are several state laws. There are state and federal laws that govern sharing of information, not just in general about your health, but also about HIV status, about mental health and substance use information. So 42.2 CFR, for instance, is an important federal regulation. So we take those very seriously. We follow those. We have also, though, recently come up with ways that we can share relevant bits of information with our partners in corrections so that it's not necessarily sharing the medicine that I'm on, but it could be saying, look, this is the trigger for patient ventures. This is the thing that may set him off. Look for this. Things like that help us prevent bad outcomes because, to be fair, the correctional staff are with the patients much more than we ever will be. And so we have to build this team approach that involves sharing of some information that's in the patient's best interest without violating their confidentiality.
Thank you very much.
So we're going to go to Councilmember Vallone. We've been joined by Councilmembers Barron and Levine. my colleagues, we're gonna put each one of you on the clock because we only have this room until 1 p.m. and we have dozens of people who want to testify, and we still haven't heard from Corizon. So if folks could try to maybe even not take their entire time, that would be great. Councilmember Vallone, followed by Councilmember Cabrera, followed by Councilmember Drum.
Thank you to the chairs for this very important hearing, and I think probably I have spent the last decade either on the Board of Corrections, now as a council member. There are systematic issues that will not be resolved today. I very like the answers we're hearing today, but I have to tell you, if I could bring up the testimony from 2003, 2005, 2008, last year and today, it was the same answers. It was, we need better coordination between the Department of Corrections and the Department of Health. We need more providers for contract providers when the RFPs go out to bid, yet we only have one. We had PHS, now we're stuck with Corizon and Damien. The contract's coming up in December 2015, and with this great team that's on the table there of doctors, I really would like to hear or see a new vision for what the plan is going to be when this contract comes out for bid again that will be different, to maybe enhance or entice additional community-based providers, to maybe break up, like you did last time, some of the services so it's not one giant monolithic contract that has to go out, so that we don't get stuck with one provider. That would be my first question, is what changes do you have planned for this upcoming contract? And then based on that, what other changes can we implement to deal with these systematic issues? I mean, it wasn't just too long ago. It was 2008 when I had asked the question then on the Board of Corrections, how do you get the information from intake to the doctor when the doctor or the social worker schedules a doctor's appointment with one of the detainees or inmates? And they say they had to locate the folder and walk it over to the other facility. I almost had a heart attack. So and then they put in this great case management system. I see you smiling on the corner because you were the one to testify. The case management system to allow, finally, computer systems to go throughout the island. So there are so many structural defects to Rikers Island in general that you're not going to cure all that, because you just really need a whole new system. These buildings are so old, they're all leaking, they're a disaster, there's no air conditioning. So you've taken so many steps to get us to where we are, but I don't want to continue this battle between Department of Corrections and Department of Health. Keep hearing the recidivism, discharge planning, continuum of care concerns that we hear every testimony. So I'd like to hear some of the things. So first off, because I know we're running out of time, what would be some of the changes for the upcoming contract that you could use for next RFP that we could maybe not see these same issues?
So I will say that we can't speak directly to the specifics of the contract because, as mentioned a little bit earlier, they are in very direct conversation right now between the agency, the Department of Health, Department of Corrections, the OMB, Health and Hospitals Corporation, and City Hall. But what I...
Well, not specifics, but maybe some of your policy wish lists and or budget too, because the other thing we hear every year is we don't have enough finances to put the proper personnel on the island, because that's every year.
Right.
We don't have enough social workers, we don't have doctors, we have mental health providers, and then the issue is the safety of those workers and where they can provide the treatment, and that's where you always have that dichotomy between the Corrections and Department of Health, how you can get these detainees in safe treatment, and the workers, because they have to be kept safe too. So all of that, I think, should be kind of like your wish list, I would think.
Yeah, no, and I will say there are key priorities here. Worker safety is absolutely one of them. Assuring that quality care is delivered in an appropriate amount of time within also recognizing the financial realities of the situation and being very clear where the limitations are so that we can be very concrete and specific about additional needs. There are a few really clear tenets as we're thinking specifically about a new model that we're considering. I mentioned them earlier in my testimony, but I'll just reiterate them here because I do really think they're clear guiding principles which really help us envision what the possibilities are. One of them is really thinking about the extraordinary services that we have throughout the city, health and hospitals, the medical schools. As mentioned, you said earlier, the Department of Corrections and Department of Health, this has come up in prior testimonies about the importance that we collaborate and think very carefully about the way we provide care so that it's most efficient. Let me just say, in this administration, I can't speak to the many administrations before, but as I sit and participate in these direct discussions, these conversations are happening in earnest, and I think there are real practical ways in which we'll see already manifestations of those, from all the way down to.
Is there talk of getting the medical students involved for internships there? I know there was some federal bar to that, and we were trying to find a way to remove that so we can get additional interns and volunteers through our future doctors that are coming through to actually spend some time there. And our future clinicalists and psychologists and all the rest that wanted to help. Is there any movement to doing that?
Yeah, so there is, just confirming that there isn't a bar to that. And I think the point that you're making also is, are we utilizing those extra resources that we haven't historically probably taken the greatest advantage of to improve our services? I think that's an absolutely appropriate thing to think about, but I would also say that the thing that we're concurrently thinking about is, what is the larger vision? How do we create the larger infrastructure so that those extra resources that we can think about do get efficiently integrated into the system and used to improve care delivery? So having a resident there, a fellow there, is a great way not only to provide really attentive care, because those people come in passionately to the service, but they then become people who become committed to care delivery as a tenet of their career trajectory. We need those people. Correctional health services all over the country needs those people.
And I would
so
just
that's
ask,
a clear advocate.
not even as a question, as a last point, I
Yeah.
just checked with our chair. So the information that's provided to the Board of Corrections on a monthly basis is not coming to the council. So I'd ask now that the reports that are brought to the Board of Corrections from the Department of Health, and the same request is going to be made to the Department of Corrections, is brought to the proper committees at the council so we can have that information for our future hearings.
Okay, thank you for that comment.
Thank you.
Thank you, Councilmember Vallone. We're going to go to Councilmember Cabrera, followed by Councilmember Drum.
Thank you so much to all the chairs. Welcome. I have to tell you that I am really baffled, and I'm lost for words that so many of the inmates who are mentally ill and have a substance abuse problem are not getting the services. I can't even think of any other system in the city that where you have 2/3 of its population that they're serving that they're not getting the proper services. So following up with Vallone's question, and I know you don't want to get into specifics about the contracts and so forth, but what ended up happening is then next year or the year after, we come back here talking about how many people were not serving C again. So let me ask you this question. 5 years from now, what is the projected goal of the amount of inmates you're going to be able to service?
So I'm not sure exactly the question. So is this in reference to the mental observation units?
Yes.
So the mental observation units, while we are rolling out the PACE model to 4 of them, and we've sought that money just recently, I think that all of the mental observation units that people are in are places that have mental health staff that's far in excess of what's in the general population center. But our goal is, and it's not just our goal, it's our obligation is to provide the level of care that every single person needs in the jails.
But maybe I misunderstood that you have inmates who are mentally ill and have substance abuse problems that are not being serviced, correct?
No, that's incorrect.
Okay, so explain me about the 2/3 of the population that was mentioned earlier that you didn't have the capacity for.
So I may have misspoke.
Okay.
That is not a lack of capacity.
Or maybe I misunderstood.
The difference is that the PACE units I referenced, so we have about 20 mental observation units. Those are all high-level units. So
Okay.
unlike a regular general population setting, all of these 20 mental observation units have mental health staff that come. They do groups inside
Right.
these units. It's a higher level of staffing. What we found, however, is that, and the people who are in those units have higher levels of needs.
Okay.
However, even amongst that commitment of higher levels of staff, higher levels of resources, we found that we need to do more, in particular more for some of the patients that are very acutely ill. So the first, and these are the PACE units. The PACE units are even a higher level of commitment. So the first PACE unit we opened is specifically for people that have just come back from the hospital. So there's only a handful of people coming back from the hospital in a given week. It may be 5 or 10 people a week coming into this PACE unit. So it wouldn't help us to have, 150 PACE beds for hospital returns, but we built one and we may need a second one. The second PACE unit we opened, and this is the second of 4 we have support for, was for people that seem like they're subacute. That is, they're maybe getting worse than the regular mental observation units. They need a higher level of care.
And those are the ones where we find in the gap.
And well, the gap is filled with this PACE unit. So they go from a regular mental observation unit, they go to a higher level unit called a PACE unit. We have 2 more of these PACE units that we're going to open in the coming months. That's not to say that, we don't think there might be a role for other PACE units, but, 2 years ago, there were 0 PACE units and 0 CAPS units. And because we took the data and not just the bad outcomes that people know about, but the data behind them, we were able to, go to OMB and go to our partners in corrections and come up with a model that we don't think is done.
So, because I have less than a minute here, so let me ask you 2 quick questions. Have you talked to the courts instead of sending, especially people with substance abuse problems, into the jails to go into inpatient programs? Because essentially they're going to get the same service, different environment, and probably better services than an inpatient program. And do you have a mentorship program set up so when the men and the women get out of the system, that they have some kind of a follow-up?
Sure, I'll let Deputy Commissioner Berliner take the mentorship training program. But so your first answer, yes, we actually have a very high-level substance abuse program. It's very successful. It's called A Road Not Taken. And so a lot of our referrals come from the courts. People come from drug courts. But these are patients who have high levels of substance abuse, specifically substance abuse needs. And we work very hard. We have community providers come in and meet them in the jail, and then they go to inpatient and sometimes outpatient, but many inpatient substance abuse treatment after jail, and it's a very successful program.
Okay, thank you so much.
Councilmember Drum.
Well, thank you very much, Mr. Chair and chairs. Thank you for the opportunity to ask some questions. I agree that that the Road Not Taken is a successful program, but I just don't think that it gets to enough people, and I have questions about that as well. But I want to go back a little bit to Suicide Watch, because I think that's a more pressing need at this point. From my understanding, at the February 10th, 2015 hearing with the Board of Correction, it was mentioned that Suicide Watch would be implemented in the ESH, the CPSH, and the 5 North units. Is that correct?
The ESHUs, the Enhanced Supervision Units, are not mental health units. Patients are not going to be there on Suicide Watch. However, what the Department of Correction has done is if somebody is identified as needing a Suicide Watch, in the hours that it sometimes takes to transfer somebody off that unit, there are cells that they could be in while they're awaiting transfer. But security units, whether it's the CPSU, which is the regular solitary confinement, or the ESHU, aren't places that we're going to be doing Suicide Watch.
So you would agree the treatment should not be in that setting?
That particular thing, that's right.
For Suicide Watch.
It's a very complex task.
How do you identify people on Suicide Watch?
Well, actually, many people come to us through correction officers saying that a patient said that they were despondent, or they said that they were going, they made a comment. We also have a large general population mental health service, so out in the regular housing areas, people are seeing mental health. However, Suicide prevention is everybody's job in jail. If you work in a jail, if you have any concerns about somebody, whether you're a security person, a health person, a medical person, a pharmacist, it's your responsibility to get that information to the right place immediately. And so we have lots and lots of referrals that come to us, but once we know, or we suspect, or even we're worried that somebody might harm themselves, it's our responsibility not just to work with corrections that they be watched, but to do a real clinical assessment of what are the risks today that this person's going to harm themselves, and do they need some type of care that we didn't know about or that they didn't get before.
I'm glad to hear you say that it's everybody's responsibility on the island, and I think that's a good approach. My concern is that I've read in the newspapers, in the Times, and in the Daily News, instances where suicides might have been prevented had corrections officers been watching and doing what they're supposed to do. And in several instances where it was identified that they may have been negligent, very little discipline and no prosecution took place. What type of measures are you implementing now to ensure that those who are not doing their job in terms of suicide watch, even though they may be there for a few hours between the transfer between the unit they're in to the treatment setting is taking place, what are you doing to ensure that the proper approach is taken by those corrections officers?
I'll turn to Deputy Commissioner Berliner.
Eric Berliner from the Department of Correction. So the point you raised is obviously an extremely important one. One of the things we've done over the last couple of months, and we discussed it at the board of correction meeting in February, is we've tightened the procedures that we have in place for the ways in which suicide watches get initiated. So at the moment that a mental health clinician provides a suicide watch determination for a patient, the officer who receives that piece of paper becomes the suicide watch officer. In the past, that person is called for a watch officer, and usually the inmate sort of remains in the area, but we've made that person responsible for constantly observing the person in front of them until the suicide watch officer arrives. In addition, we're focused on the responsibility to get that person to the care environment that they need. So the only responsibility that the officer has beyond the constant observation of the person in front of them is to notify their area supervisor, who becomes responsible for effecting a transfer either to the mental health center or to a mental observation unit or to the clinic, depending on the appropriate circumstance there.
Do you have an estimate of a number, or do you have an actual number of how many people might be on suicide watch at any given time?
Usually about 30 to 40 per day.
And you have enough officers to cover that?
Yes.
Let me go because I think I have 18 seconds left and I want to get this in. I have an education committee hearing as well today that I have to go to, which I chair. The road not taken. I see from the numbers that the council gave us, in fiscal year 12, there were 579 people who completed the 45-day substance abuse program. In 2013, it went down to 354. In 2014, it went down to 257. Why is that happening? I don't think there's less people with substance abuse problems on Rikers. And is that because a different program has been put in? And also, I would just like you to address briefly how the follow-up is conducted. I have known people who were referred to the program who were put into general population because there was no room for them in the Road to Recovery program. And actually, the paperwork was lost between the courthouse and Rikers. So can you go over that for me a little bit?
Sure. So the Road Not Taken is a very high-level unit because it's a special housing area for people, often referred to from the courts. So we rely on the courts often to refer people to us. Also, people tell us on intake if they have special needs. We then turn over lists of people that we want into the unit to the Department of Corrections, and then we have to coordinate getting them there. And so that actually can be quite a cumbersome process. I do want to say that the funding we received from the Mayor's Task Force to do discharge planning for people with substance abuse issues, this is to bring this approach to people with lower levels of need that aren't going to go into this a very good silo. It's really a silo, right? It's high level. It's a high level day treatment facility. So we're going to be rolling out. We're going to be hiring staff and rolling out discharge planning, where we find people with substance abuse problems that didn't come through the drug courts, but as you said, the many others who have these needs and who really do need help coordinating connection to some care outside the facility. So those staff that we receive support for are going to be doing just that for the people outside the Road Not Taken program, because the Road Not Taken program is very successful. It's very small. We do rely on both referrals from the courts and also this very high level of coordination between us and corrections to get people into the unit while they're still in jail.
So did you answer the part about the number of people referred from the courts and the number of cases you're able to deal with that are actually placed in the program?
So we have I'll have to get back to you because I don't know. I believe it about a third to a half of the people are coming from the courts, and I don't know what's happened with the number of court referrals over the year, but we certainly will give you a comprehensive response.
Sure, and that number has just dropped. I mean, it's less than half of actually what it was in fiscal 12.
That's right, and so I apologize. I'll have to get those exact numbers for the court referrals back to you.
Okay, thank you.
Thank you.
Thank you, Councilmember Drum. Before I go to Chair Crowley, I understand that there has been some concern that's been raised that the reports in the bill that's been proposed should be posted on the department's website and made publicly available so that people have access to this information. I agree, and this is something that we will look at and discuss as this legislation moves forward, the reporting measures that I'm talking about. So I also encourage anyone here today who has any recommendations on how the bill should be changed to please give us feedback as this moves through the legislative process. And now I want to turn it back to Councilmember Crowley. Before that, we've been joined by Councilmember Matthew Eugene.
I'm troubled by the reports of healthcare workers being beaten and physically abused by the inmates. Last year, there was a 144% increase from 2013 to 2014 in assaults on healthcare workers in your facilities. What is DOC doing to make sure that their safety is a priority? I've met with the Doctors' Council. I understand that there are risks there that could be avoided if DOC was to ensure that correction officers were in rooms when the healthcare staff is seeing violent inmates. And I also understand that there are physical limitations in the structures that limit sightline and create a real danger for those healthcare workers. So this increase in assaults, one assault is too much, but to see that it's increased significantly, we need to know what DOC is doing.
Sure, and I just want to start by saying we take this matter extremely seriously. I agree with you, even one assault is too many. We've gone facility by facility with medical staff at the facility level, with maintenance and construction staff, and with facility uniform leadership through every jail in the system over the last several months, and have made comprehensive lists of areas that require some modification. Some we're able to remediate right there while we're standing there. Others, of course, take more time for planning and construction. But the goal is to make to the degree that we're possible within our facilities, the goal is to make the areas safer, provide better sight lines, or physical plan improvements. We've added panic alarms to, I think, nearly all areas where medical staff see patients. And we are working with the clinic staff to ensure that officers are appropriately positioned so that they can see inmates and their medical providers in treatment areas. We're also doing the same work in the housing areas in which medical care is provided at the housing area level, so that's typically mental observation areas or infirmary settings. We've gone place by place through those areas to make sure that we've got the best possible set of physical plant circumstances. We've also done trainings with medical staff in all the facilities. Those are conducted by a senior member of our security operations division and a uniformed member of my staff, who are doing situational awareness and medical staff safety trainings for medical staff in all facilities. And those will be continued on an ongoing basis as refreshers or as new trainings for newly hired staff.
There was an awful attack on a healthcare worker that was leaked to the press, a video of such an attack. And we find out later that that inmate was known to be violent and abusive towards specifically women. But the healthcare clinician had no idea that this particular inmate was that violent. And there was no correctional officer that could have stopped this inmate from attacking. How can we be assured that enough staff, especially the correctional officers, are there when there are violent inmates, and to also make sure that the healthcare staff knows that they're about to see somebody who's been arrested for a violent crime or convicted of a violent crime?
Yeah, that was obviously a particularly shocking circumstance.
But I'm looking at the numbers. So that,
No.
that was one example we saw the video footage of.
Yes, that's right.
But the numbers are saying that this happened last year, a significant increase last year.
So what we've done about that is, and Dr. Venters mentioned this a little earlier, is about the communication that's going on the units. This is not just unique to the CAPS or PACE units. It's true in all mental observation settings. The staff at the beginning of every day discuss with one another everybody who's on the unit and any issues or people of concern. One of the things that has been historically true and that incident that you raised pointed out to us is that for many, many reasons, information about inmate criminal status is rarely communicated at the housing area level. It's just, it's available to the officer.
The moment that officer, the moment the DOC is doing the intake, the medical intake, you see, you pride yourselves as being a facility that, unlike any other jail in the country, within 24 hours you have a medical assessment. Can you not put on that medical assessment what the individual was arrested for? This way, any medical staff seeing this individual later on will know that?
We
Are you
certainly
limited? See, I know that there's limits to what the officers can know about the health status of the inmates, but can your healthcare staff know about what the inmates have been arrested for? It's public knowledge. I mean, if they do the research, can we just make sure that they're aware, so that when or before they're seeing the inmate, they're prepared, more prepared. I mean, and you can prepare and train the medical staff all you want, but when you have a violent inmate that's about to see the medical staff, we need to be assured that there'll be enough correction officers there protecting the healthcare staff.
Yes, of course, I agree. We can share charge information, and the problem is that doesn't always imply the circumstances of the charge. So an assault can mean many things, and it wouldn't necessarily provide information that the person was assaultive toward women. What we have at the shareable level is just the basic charge data, and that's not an issue. As I said, we're going facility by facility and location by location to make sure that where health services are provided by staff, that there are enough officers and that the right sight lines do exist. And we're not going to do that once and then say, okay, we're done. It's a continuing process to make sure that everything changes,
Mr.
anything that
Berlinger,
changes.
I'm not going to ask any more questions. I'm just alarmed by the increase because it's substantial. And even though it appears that you're doing more and what you're saying in your testimony, the numbers don't lie.
Thank you, Chair Crowley. We're going to go to Councilmember Barron.
Thank you to the chairs and thank you to the panel. I will have a chance to review your testimony. I wasn't here to hear it directly, but I have a follow-up question following up with Councilmember Vallone and Cabrera about 2/3 of the population, and you said, no, I misspoke. So I want to understand, what does the 2/3 refer to? Are you saying that it's not that number of patients who are not getting the services, or is it another number? And is everybody being serviced fully? So what is the 2/3 and what is the population that is not being serviced?
Sure. So we have about 20 units that are called mental observation units. So those are units where people who need a higher level of mental health care go.
Yes.
So all of those units have high levels of staffing.
Right.
They have staff that come that do groups on the units. They take care of people on the units. We bring the clinical staff into those units. And those are, by and large, for people who are seriously
Right.
mentally
But
ill.
what does the 2/3 refer to? I missed that.
I believe somebody asked how many of the mental observation units have been converted to the PACE units. Now, the PACE units are...
Is that what the 2/3 is?
Well, I think that somebody had put together PACE units and CAPS units. So if you think about the MO, the mental observation units I mentioned being like hospital, in a hospital, and then in a hospital you have a small footprint of places that like an intensive care unit where you have even higher levels of staff. So the PACE units, we have 2 that we've opened, and we have 2 more that are about to open in the coming months. Those are some of these mental observation units where we've gotten funding for an even higher level of staff for the most seriously ill folks.
Is every inmate getting all of the services that they're entitled to every day?
In the jail system, I would say no. There are some.
What percentage is not getting the services that they are entitled to or that they are expected based on a plan of a medical observer, a medical practitioner, a mental practitioner?
It depends on the type of care. If we schedule, for instance, 100 visits, probably a third to half of those people will come to the clinic, and they may not come to the clinic. They may not get their care because they refused that day or they were doing something else. And so then that care then gets rescheduled for the next day. And
So you're saying 1/3 is perhaps not getting the services that are outlined on a care plan?
No, I think that we would actually have to have a much more specific question about, we have 10,000 patients,
Yes.
And we have lots of types of care. And so I
Yes.
think that I couldn't give you a number for all the different types of care that we give and who might miss what on a given day.
So then we don't know where the problem. This is a big problem. If you can't tell us whether a person is getting what they need based on a chronic medical condition or mental health or substance abuse, you can't give us a number as to how these inmates or detainees are being serviced. That's serious.
Well,
That
so
we don't
you
even
just-
know.
You just gave me some specificity
Okay.
that I can answer.
Okay.
So, for instance, one of the performance indicators we have is for chronic care.
Yes.
People who come in who are diagnosed on the intake with diabetes, hypertension, a chronic medical problem. We then measure the performance of both Corizon and Damien in terms of getting them their chronic care visit. That's one specific thing that we can measure.
So, and what does that measurement show?
It shows that quarter over quarter, about 90 to 95% of the visits that are supposed to happen on time.
Okay, and then substance abuse?
So substance abuse, again, we look at the people that are referred, that come in, that are referred to a program. And so substance abuse, we actually have 4 or 5 different types of encounters. I will say that we have 40 performance indicators that we mentioned in the testimony that
Okay,
you'll
and
see.
what percentage would you say is reported as having received their services?
Again, 90 to 95%.
And then for mental health?
So mental health, we look at both the timeliness. So if I'm a medical doctor, if I refer somebody to the mental health service, we want that for most people, like in the community, to happen within 3 days. There are also some stat referrals that happen immediately. But the mental health referrals, between 80 and 90% of those generally happen within the 72 hours.
Okay, so those are the referrals, and then the plan that's devised for them, that's maintained at that same degree of 90%?
Well, so the plan, there's no one plan. So in
Right.
the mental health service,
But
we have,
whatever the plan is for those persons that are in the system.
Yeah, so jail care is very different from the community because
Okay.
in the first 3 times we meet a patient, we may change their plan 3 times because every time we're checking community records, we're getting to know them better. So the
And
plan,
when the final plan is resolved, is that maintained? What's the level of maintenance for that plan, whatever that final plan is?
So again, I'm not sure that question isn't really specific to us. I think that
Okay.
we try, so for instance, medications, we measure how often people get their medications. So we'll look at the frequency with which people who are prescribed a medication get it. And we find that if they don't get their medication, it's often a combination of refusals. We haven't done a good job sometimes working with people to increase their medication compliance. We don't have one care plan that can be measured just as a one-off, but we have many, many measures. As I mentioned, we have 40 measures that we look at, and the compliance rate for those measures is either 90 or 95% most of the time.
Thank you, Mr. Chair.
Thank you, Councilmember Barron. I have a bunch of questions, and we're going to try to rifle through these as quickly as possible because I know that we still have a lot of people to testify, but these are questions that I'd rather ask in a hearing setting than wait for written answers. So do you think that there is any inherent limitation in having a for-profit company provide services as opposed to having a mission-oriented provider? I mean, I'm not against having a for-profit contractor. If you can get the job done, great. But I question whether Corizon has the drive to strive for excellence and go beyond the minimum standards that were laid out by the Board of Corrections. I wanted to hear your thoughts on this, Dr. Angel or Dr. Venters.
So I think it's an important question, and ultimately I think there's no simple answer to this. Absolutely, the kind of institution or entity that provides the best care is the one that's best qualified, best resourced, and best organized to be able to deliver that care in a systematic way, and also done in an environment where the oversight institution is committed to health as well. I think in this instance, uniquely in New York City, this isn't common in many other situations, we do have the Department of Health that is overseeing the delivery of care, and through that mechanism, it provides us with a means to really understand and assure that the entity that's providing care will be meeting the mission and needs of the patients at large. I don't think that it's either one or the other. This is my assessment of having viewed this, but I do think that it's very important that we have an entity that meets the requirements and needs of what that administration has, and I think that's what we're facing right now as we look at this contract coming up for rebidding.
Thank you. Who is on the Quality Improvement Executive Committee? Who sits on that committee?
Sure. So it's chaired by Commissioner Bassett, and then the senior staff who sit on the committee are senior physicians and a couple of other senior health staff in the Department of Health. And then once a quarter, we come, myself and my team, as well as Corizon and Damien, come report out the 40 performance indicators I mentioned, how we did on them. We also report out things like morbidity and mortality reviews.
Are there any Corizon or correction staff that sit on that committee?
So the committee is the oversight. So Corizon, it's the oversight of Corizon. So Corizon wouldn't sit on the committee, but
Is
Corizon
corrections?
comes to report out. No.
Is correction?
No.
I mean, I'm just wondering, would it be helpful to have more stakeholders who are involved in the on-the-ground work to actually sit on that committee? And is it helpful to potentially have physicians and clinicians who are at Rikers to sit on that committee? Would that be helpful in understanding things a bit more?
So as I mentioned, the physicians and the health staff who work at Rikers are working for Corizon. So this is the committee that oversees Corizon. So it certainly would be innovative to have the people who are being overseen also be on their oversight committee. However, we do work closely in preparation for these committees, and certainly certain parts such as investigating deaths, which we report into this committee. It's a collaborative process with corrections because we benefit from their insights and knowledge into what happens in a housing area before we have a patient come into the clinic.
So what are some of the lessons or recommendations that have come out of that committee, out of the Quality Improvement Executive Committee, that you can share?
Well, we've talked about several of them. The PACE units.
That came out of that committee.
Well, that committee reflects the work of everybody who works in the health system. And so, yes, so we brought to the Commissioner and the Quality Improvement Executive Committee the findings from a couple of cases, one of which you mentioned, and the fact that we didn't think that we had met the standard of care. And really our concerns were not simply about individual errors, but that we had a system of care that needed change. And so the PACE units, like the CAPS unit before it, is really a fundamental improvement that's come out of this process.
You said, Dr. Venters, that health staff and correction staff earlier, when you answered my question, that they have the opportunity to train together. How often do they train together? And when such staff requests trainings or have ideas, are those requests granted?
So we support training in a lot of different settings. So it starts actually with the academy for the correction officers. We have health staff that go and talk about, not just about mental health issues, but our medical director, Dr. McDonald, has just been out to the academy to talk about traumatic brain injury, which is very high prevalence among the adolescents coming into the jail. It's important for officers who are looking at kids with behavioral problems to know about traumatic brain injury. So we start at the academy with the officers. Then when people get to the jails, when they work in the clinics, but also when they work in these special housing areas we've been talking about, we roll out all these housing areas with joint training. So the CAPS unit, the PACE units, Commissioner Berliner mentioned that on all the mental observation areas.
So how often do the trainings happen? Between corrections and health staff?
It would vary by type of training. There are refresher trainings that happen for mental health professional trainings, and that's a corrections training.
And
I
is it
don't
like
know.
once a year? Is it 4 times a year? Is it once every 2 years?
We do the trainings each time we open a new unit, and then we try to refresh it every couple of months to make sure that it's.
Well,
it's
what does that
staying
mean,
with the
try
staff.
to refresh it? Like there's no set plan? Who makes the decision when
Well,
there's going to be a refresher?
In each case, so on the PACE units which are new, we haven't obviously yet done a refresher because they've only been open for the past couple of months. At the CAPS level, there's staff level training that goes on every 2 to 3 months, and there's mental health leadership and DOC leadership in the facilities who make a decision about whether or not people need another round of the training or not, and then we bring that training to them.
To what extent do you all engage staff on systems reform? You know, if they believe that there needs to be some systematic reform implemented, is staff engaged in those conversations?
We wouldn't implement a systems reform without the staff. So
Okay.
that's the same.
Okay. Dr. Venters, I appreciate that you identified the PACE and CAPS programs as responses to what you all saw as potential system failures. It was an innovative way to try to take care of the seriously mentally ill. What are the biggest system failures that you all have seen? If you could maybe name the top 3, and if you could tell us who you think was responsible for those to help us understand how we identify system failures when they occur.
So we, through our morbidity and mortality process, often identify systems problems with the delivery care. These aren't problems that we identify and fix and then they're done. These are persistent problems that everybody who works in the jails is aware of. So one area that was referenced by Councilmember Drum is how do we handle patients that we put on a suicide watch or need to go from point A to point B for a mental health reason. That is an area that has persisted for us as the 2 agencies, and I think that's one of the top concerns. So we recently have developed new communication and reporting strategies that make sure that everybody knows when a patient needs to go from one setting to a higher level of mental health setting, particularly patients on suicide watch. And the way we've done that is by the measures, DOC has taken the measures that Commissioner Berliner mentioned, but also on our side, we actually have a uniform reporting tool now that goes around overnight every 2 hours that tells us every patient that needs to be transferred into the mental health center. Everybody knows that. Everybody, both on the DOC leadership side and the health leadership side, Corizon, we're all tracking the hours that it's taken to transfer somebody. So that's an example of a systems problem that has been a very grave systems problem that's been associated with morbidity and mortality that we've developed a systems fix to.
That sounds great. I mean, that's what I was looking for, to understand, where you've seen problems and then how changes have been made to improve those type of things. I think that's what we're looking for, to get better and to see where there are potential failures and what we could do better. I just want to touch on this briefly. Dr. Venters, is it your opinion, someone who's there on the ground at Rikers? I know that Corrections announced in conjunction with the administration that we're going to be getting rid of solitary confinement, punitive segregation, whatever you want to call it, for adolescents, 16, 17, and 18-year-olds. But there's still going to be widespread punitive seg used amongst the general population. Do you believe that punitive segregation exacerbates people with serious mental illness? That it harms them?
Well, as an epidemiologist, I'll tell you what we know from our data. This isn't my conjecture. It's that if we look at self-harm, the act of harming oneself, as an outcome we all want to avoid. And we also look at high lethality self-harm. That's self-harm that could lead in your death. We find that the groups of people that are much more highly disposed to be in the self-harm group are kids who are adolescent, people with serious mental illness, and people who are ever in solitary confinement. We've published that data. We're the first jail in the history of the United States to publish that type of data. And it's not, we in our hearts have felt that as clinicians on the ground for a long time, but what should move policy is not simply what's in our hearts or what we care for about our patients, but what our data shows.
Well, I appreciate you sharing that, and you're absolutely right. That is what should inform how we handle these type of things. It's my opinion, not as a clinician, so maybe my opinion doesn't count as much. I mean, I think punitive segregation and solitary confinement is cruel and unusual punishment, and I don't even know how. I don't believe it should still exist in our correctional systems in the city or across the country. And I hope one day we get a ruling that says such, that we can actually rehabilitate people instead of harm them even further or hurt them in a way that they inflict self-harm. So I want to move on quickly, and then we're going to have Councilman Rosenthal, and then we're going to be done with you all. And I really appreciate you guys sticking around and being so helpful. So we don't have much time remaining. I want to shift from the mental health issues to issues relating to medical care. I have a lot of questions, and staff will send some of these along because we're not going to have time to get to all of them. Who manages the scheduling of patients?
So the clinics, the individual clinics, have an administrator, they have doctors and nurses, and so the nurses will schedule the nursing follow-up visits. The doctors and physician assistants will often schedule their follow-up visits. If they're, for instance, let's say a chronic care visit, that they'll decide the person needs to be seen in a week or two.
What happens if someone refuses a scheduled medical appointment?
So they're, depending on the type of encounter, but generally what happens is they're brought to the medical clinic, and then they can refuse. That's where they sign a refusal, just like you would in a hospital, where it's witnessed by a healthcare person. And then there's a discussion. If they refuse multiple times, then it depends, do they have decisional capacity? Do we need a mental health evaluation? Are they getting sick? Or did they actually end up being scheduled for things they don't need, which happens in our system?
When the Department of Correction fails to produce a person for his or her appointment, or the person does not appear, what action does the clinical staff take?
Well, the clinical staff is faced with this circumstance many, many times a day across the jail system. And so what they first do is look and see about the severity of the illness and the implications, the clinical implications for not having care. If it's somebody who wanted some hand lotion and they didn't come, nobody's going to go out to the housing area. But for patients that have life-saving medication, who have life-threatening disease, often clinical staff and administrative staff from Corizon or Damien will go out into the housing areas and work with correction officers to get them connected to their care.
Is the health staff given a reason why the person has not been presented?
Generally, no.
So when someone doesn't show up, is each incident tracked? You said often there's follow-up, but if every time that someone doesn't show up, is that put into a computer system?
Yes, we have an electronic health record.
Okay.
All of our visits are scheduled in there.
And what if the person is not getting the life-saving medicine or treatment that they need? What happens? What type of intervention occurs?
Well, we talk to the patient and we find out why. And if it's somebody who's missed mental health medications, there's a consideration. Do they need a higher level of care, transfer to the hospital? For medical medications, they may need to go to the infirmary.
But is that incident always flagged for the department? Is someone flagging that so you know that that's happening?
Yes, the site medical directors, the directors of nursing, and the health service administrators of every jail, that's a big part of their job every day.
So we have a lot of other questions that we're just not going to get to. I'm going to turn it back to Councilmember Rose. I'm going to turn it over to Councilmember Rosenthal, and then we're going to move on.
Thank you, Councilmember Johnson. I'm going to go really fast, so if you want to pick up on a few things, I don't want to get in your way. This has been an amazing hearing. I'm sorry I could only just jump in now. But I guess fundamentally I want to understand if there's a budget problem here. And, and I guess the way I'd ask it is, I know that money was added into the budget, and I'm sure that'll go a long way. It's a lot of money. But given the nature of the mental health demands of people coming into Rikers and what happens to them on the island, do you feel that the systems are in place to identify people with mental health needs, and that we, especially with the additional funds, are taking care of people reasonably well. From an epidemiological standpoint, this could be a point of entry, right, for access to care for somebody who wouldn't otherwise get captured in the system. Is there an opportunity here that we're missing? Maybe.
So we actually, because we have such a large intake history and physical, it looks like a hospital admission, we really do a good job of identifying people coming into jail, I think, as best we can in a jail. I think it doesn't mean that we don't have people that we don't identify in the first few days. I think that we routinely will find people that we didn't come across in the first few days that a correction officer or somebody else refers to us. I think, though, that we do believe there's more to be done because, 2 years ago we didn't have the CAPS unit and we didn't have the PACE unit. And so we really are pushing reform of our approach to the sickest patients. We don't feel like we're done with that process. We think that we need to improve the quality of the units we have still, and we also need to think about the structure of the units. So the 2 new PACE units will be coming online in the coming months. So we don't believe that we're done. And you're absolutely right that not only is jail a place where we find people who had problems in the community that went untreated, but it's also a place where we treat problems that stem from exposure to the jail. So jail confers health risks to people. We must account for the fact, and it's the responsibility of the independent health authority to account for the ways in which jail confers new health risks to people. This is not simply their own personal risk that alone might have led to a bad outcome. And so all that's very complex. We certainly believe that we have more to do.
Is that type of information you talked about 2 different categories of people then? People who come in with issues, people whose issues are either exacerbated or started once they're in. Do you capture that information on your electronic medical record? And how long have those I'm sorry I missed this, already came out, but how long have you had the electronic medical record? So how far back in time could you go?
We started collecting it in 2008. And yes, we absolutely do track both of those types of concerns.